Welcome everybody to today's AMA, American Medical Association ChangeMedEd webinar, Precision Education in Medical Education, On-the-Ground Initiatives and Learnings. My name is Dr. Sanjay Desai. I'm very honored to be your moderator for today's live event, and I'll be soon introducing our two experts that will be joining me in conversation. I'm the Chief Academic Officer of Medical Education at the American Medical Association, and as part of our ChangeMedEd initiative's new focus on precision education, the AMA has supported a supplement in the April 2024 issue of Academic Medicine. It's entitled The Next Era of Assessment, Advancing Precision Education for Learners to Ensure High Quality, Equitable Care for Patients. In this supplement, authors compel readers to consider a next era of assessment that takes place and that places the focus of assessment to ensure high quality, equitable care for patients. The system of precision education and assessment is an approach that meets learners where they are in their development and helps them take specific next steps needed to continue that development. This webinar features authors from the ChangeMedEd supplement in academic medicine who are taking novel approaches to apply precision education and use data and technology for the effective assessment of learners at their own institutions. At the end of this webinar, participants will be able to, number one, discuss insights and transferable learnings from the application of precision education at two different health systems. Number two, understand common challenges and best practices to implement precision education to ensure ethical development of future systems. And finally, number three, to learn how adapting a common framework to develop and assess precision education initiatives can lead to a clearer understanding of the impact, help to mitigate potential risks, and allow deployment of successful practices on a larger scale. I'm really honored to introduce our two panelists for today, both co-authors of papers that are in this supplement. The first is Dr. Brian Garibaldi, who is a professor of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University. And second is Dr. Eric Warm, a professor and program director in the Department of Internal Medicine at the University of Cincinnati. Thank you both for taking time out of your day to join us today, and we'll turn it over to Dr. Warm. Actually, before Dr. Warm starts, I wanted to go through, I think it'll be important for me to go through a little bit of housekeeping. So before we begin, I have just a couple of things I wanted to mention. The first is that during today's webinar, submit your questions in the chat box. We will try to address them during the presentation themselves and try to get if we don't do it right through the chat, then we'll try to get to them certainly during the Q&A towards the end of the webinar. Following the webinar, please take a moment to answer our short survey. It helps inform future events for us, and you can do this by clicking on the third button below at the end of the presentation to access the survey. Lastly, this event link can be used to take a quiz and earn CME credit. View the webinar on demand and to read the transcript itself. So with that, we'll turn it over to Dr. Warm. Thank you so much.
Thank you, Dr. Desai. So my talk today is entitled, my part of it, it's implementation lessons for a positive behavior change. The key lesson there is on the word positive. And so hopefully you'll be able to use what I'm going to say to think about how to develop clinical learning environments that foster the word positive behavior change, because you can always cause negative behavior change and you don't want to do that. I have no disclosures. So I'm part of a research lab here called Radical. I love the name of it. It's research and assessment designed to improve care and learning. And our motto is to improve care through learning. So the idea is that you can drive positive learning change and negative learning change. And when you teach somebody something and they learn it, the question is, what are the outcomes at the level of a patient, of a system? And so we're trying to really pay attention to that. When you're thinking about gathering data for assessment, it's kind of complicated. These are all the kind of research streams that we are working on. The first is data acquisition, that top line. There are so many different ways to gather data in assessment. Programmatic assessment can be quite broad, and if you look across the top row there, you see lots of ways that we have collected data and are going to collect data. All the PM ideas or papers that kind of focus on that. Then once you get the data, you have to analyze, you have to clean it. You have to ask yourself, what happened to that data? Why did it happen? What will happen next? What should we do about it? And what don't we know about it? These are all ways to understand data. And then once you understand it, then you have to share it. You have to visualize it. Somebody's got to see it. You've got to provide it for formative coaching, which is so important. Sometimes for assessment in a summative way at the CCC level, composite committee. And you got to report it out, at least in this residency program to I do. And then finally, if you've acquired it and analyzed it and you shared it, how do you know that it's valid? What are the ways that you can prove that the conclusions you made based on your data are valid? And so it's not simple, this idea of gathering data to give back to people. It's quite complicated, and I don't pretend to think that we have all the answers yet, but we're asking a lot of good questions, I think, in our shop here in Cincinnati. Before I get to talking about some lessons that we've learned, I want to just give you a sense of the place that we work at. We have a very special thing in our program called the ambulatory long block. It's now 18 years old. In traditional internal medicine residencies are spent mostly in the hospital and then 1/2 day per week in the clinic, or do something, a different version is called X+Y, where you spend, say, 3 weeks in the hospital and 1 week in the clinic. For us, for the past 18 years, we take all the residents out of the hospital for a year, and they form an ambulatory group practice where they're doing continuous care like any ambulatory primary care physician would in an authentic space. It's longitudinal. The residents are empaneled as primary care physicians. They are responsible for the patients in ways that are authentic. And we work within a really high functioning clinical microsystem. So I'm able to generate a lot of data coming out of that particular long block. Data looks like this. This is just for effect. You can't see all this stuff, but this is one of the assessment tools that we use for the residents of the long block. And every one of those boxes and lines measures something different, from a 360 to patient evaluations to self-evaluation, testing, workflow, even refills on this particular page, and there are pages more. And this is what the paper that Dr. Desai mentioned really covers. So quite a lot of data coming out of various sources to the residents. In addition to the outpatient data, we also have sort of a global assessment, workplace-based assessment system based on something called the observable practice activities that we created now more than a decade ago, where we collect thousands and thousands of data points on each resident every year. And we use a liberal use of learning analytics to really deeply understand what it is in an analysis part of our data. So I've collected a ton of data, and I want to give that back to somebody to see if I can create behavior change that might lead to better outcomes. And what I have is collected a lot of lessons. I'm sorry, I skipped it. This is what our dashboard looks like for all the inpatient data. It's quite a lot of bells and whistles. You can read these papers if you want to see them, but we collect literally thousands of data, thousands of pieces of data, and we analyze it many different ways. This is an example of one of the dashboards that we have currently in use. All right. So here are some lessons that we've learned about when you gather data like this, how to actually create the kind of outcomes that you want. The first is to gather data from multiple sources as part of programmatic assessment, something I've already described to you. So we, again, have all these different data sources coming through to us, and more even every day, different ways we can collect data. The important thing is once you gather them, you should take a constructivist worldview. Everything has to be aggregated and interpreted. There is no truth in any of these things. The way, if you think about positivism, which is there is a truth and you can know it, I thought that's the way it was when I started collecting data, and I quickly realized that's not true. Many of us go to post-positivism, which is there's a truth, we'll get close to it, but we'll never really know it. But I think where I've landed and many of my friends have landed is it's constructivism. Everything here needs to be interpreted, and even if you can't find truth, you can still find value in moving it forward. So if you're in this path like we were years ago collecting information, know that there's no single truth that's going to tell you the answer. You still have to interpret it. I think a second important thing when you start gathering data is to engage the group to determine what should be measured. When you give people data, often they're like, well, this isn't right, I don't like it. And you argue about whether you should even collect the thing you should collect. So we just started something years ago. We started something called Defense of the Measures, where for the ambulatory kind of clinical measures, we have the residents do an evidence-based review of them every year, and they have a debate, and we vote on what should be included. We're co-producing those goals, both the things that we measure and the goals that we set for ourselves, before we even get started. Here's what one of those spreadsheets looks like. This is just an example of the inventory spreadsheet where these are all the measures, here are all the goals in the red box, and then we just sort of measure ourselves month over month. Instead of arguing about whether this is a good measure halfway through, wasting all that energy, we did an argument ahead of time. It's a strong word, argument, but we choose ahead of time so that by the time we start to measure things and start to receive feedback and give feedback, we're not arguing anymore whether it's valuable. We've already decided that. So where you can produce the goals, I think you'll get less friction when you're giving out data. Next, stage 3, if you're giving out data, you should fix any errors in the data immediately. You've seen the 7 stages of grief. Well, there's 7 stages of data, and they're the same. That's what I've learned. Often by shock, denial, and anger coming right at you. So if you're the deliverer of data and there's errors in it, they will tell you why it's wrong, and then all that energy is not going to where you want it, which is to make things better. So by doing this, you're going to build trust in the system. If people do not trust your system, they will not check your data for positive use. They will be angry at you in ways that aren't going to be helpful. So because I'm the keeper of the data, whenever there's an error, I listen hard and I go fix it. Fourth, when you're giving out data, you really should acknowledge what's known as the attribution-contribution continuum. Attribution is defined as what my direct kind of influence on the thing. I did this thing, and you can clearly see a one-to-one ratio. Whereas contribution is how I contributed to the care. And in a world in which almost, we're always working in teams, there's rarely clearly attribution because we're always working within teams, but some things are more attributable to the person than others. And so here's a box, a table of things that we do in our ambulatory clinic, for example, where we give feedback. And there are things that are clearly more on the attribution side, like a foot exam or taking a depression screen or discussing PSA. That's you and the patient doing the thing, and if you don't do it, it doesn't get done. And as you move to the right, for example, process is completed on site. The person has to leave your office and just walk down the hall to get some labs. There's a step in there that's not entirely on you because they might just go to the elevator and leave. Or screenings that require a separate visit, like a mammogram, where they actually have to come back on another day. Or disease control, which is very complicated. If you hold people responsible for these things equally without this kind of nuance, they will get angry. Well, it's not my fault that A1C was 9. That's another person, another world. I shouldn't be responsible for that. By having this discussion ahead of time, you develop a shared mental model of the work, so people aren't so angry with you when you're talking about one thing or the other. And I found this has really been helpful. And when people are not angry, they tend to act in ways that are positive and helping diseases get better. Fifth, I think you should, when you're giving feedback, to use criterion referencing and not normative comparison. This has been such an important lesson for me. If we think about the best and the worst of anything, where do we put the line of good enough? Is that here where a few people are not good enough and everybody else is fine? Or do we put it here where everybody gets a trophy? Or do we put it here and a lot of people get excluded? I like to say that it doesn't matter where you put that line of good enough. If the gap between the best and the worst is so broad, that is the problem to be solved, not where you put the line. We think this is what should happen in medicine, where the best and the worst should be so close together, and we should be asking, what is this line and how can we help everyone get there? By setting a criterion, it means everyone can get there. Let's say that everyone has hit the criterion that you set. There's going to be somebody that's going to be last, but if you tell them that they're last, even though they're good enough, that's going to demoralize them, and they're not going to want to be part or listen to anything in the future. So when we set a criterion, it has to be high and important, and if everyone gets there, we're good. We should make that bar a pass high enough that it makes the best irrelevant. Yes, the best and the worst will always be discriminated somehow, but if the gap is so small, it doesn't matter. So I think what we should be doing as educators is not worrying about the top. The top is going to take care of itself. We should be worried about the bottom and make sure that we raise that bar high enough and then help people get there. You can do that with data. If you start rank ordering people or you use normative comparisons, you tend to get negative behavior changes. 6, I think if you're going to set goals for people, criterion referencing, you should set reasonable absolute value goals and improvement goals and accept both as good. Here's a scorecard that we might give some of our residents. Those are the measures that you can see here. And then there's the goal. And then if they are close to the goal, it's yellow. If they're far away, it's red. If they hit the goal, it's green. So they can actually have an absolute value, how they did. Are they doing well, yes or no? But then we set an improvement goal for a particular, say, quarter. In this example, we just want them to be better by 2%. And if they hit the 2% goal, it'll turn green, close. It's yellow, far away, it's red. And then at the end of the day, you can see whether they hit either goal, the actual absolute value goal or the improvement goal. And if they do either one, it's a yes. And we can focus specifically on the no's where they haven't hit the goal and they haven't even gotten better. By doing this, you can focus your feedback because if people are improving, that's what you want. They don't always have to. And the reason this is important is if you come into a practice and you're giving clinical data and you pick up the worst panel of patients to start with and you move them, you should get credit for that, even if you weren't first at the end. And I think this has been really helpful. So if people are maintaining or improving, give them credit, focus your feedback on neither one of those things is happening. I think you get kind of better behaviors. 7, I think you should develop intuitive data visualization. What I showed you were our early dashboards. We've now moved into this thing called ResDash, which I'm really excited about. I never thought I'd be in a journal called the Applied Clinical Informatics, but here I am, where we spent a long time kind of figuring out what people would respond to. These are the colors that are better. As soon as you put something red out there, people's shame reflex goes up. And so we've worked really hard on creating those visualizations in something that's more well likely to be accepted, easy to understand, and co-produced, because I didn't make this for myself. We got the learners involved. We did a lot of co-production in order to get this. So people just aren't so negative about their own behaviors, data. 8 is to provide individual coaching. You should not provide data without guidance. If you do that, you tend to get into a mess. This is one of my favorite data sets. I'm not sure if you can see my arrow. I sure hope you can. But if you have this LB12 at the very beginning, that's long block 12. That's many years ago. What this is the number of minutes the patient spends in the clinic on average in the practice, month over month. First day of long block 12 is quite high, and then they spend a year getting better, getting faster. The very first day of long block 13, they went up. We were giving this data, be faster, be faster. 14, the same thing. It wasn't until long block 15 where we started a coaching program from the very first day on how to be more efficient, and we have decreased that spike. And we think we can even do better still as we're going on here. So if you're going to give all this data to people, someone needs to sit with them and go through it piece by piece. Otherwise, you probably aren't going to get any improvement. But again, you might go where you don't want to go. So I find this is actually worse, not for residents, but for faculty. Faculty often get data, but nobody's helping them with it. And that's probably not your ideal way to deal with the data. Number 9, if you're going to be an organizer, if you're going to do all this work, you should show the sum of everyone's work. What you're seeing here is the percent of patients with uncontrolled diabetes for 10 years in our practice. And somewhere around 2021, we got a hold of the GLP-1 agonist plus some really good quality improvement tools, and we got better. So everyone that's been part of this data stream for the past 4 or 5 years has seen that their efforts are helping at a global level within the entire practice. Connecting the meso level, which is me in the clinic, to the micro, me, the person, to the macro, to the entire health system, has been extremely satisfying. And if you don't have a way to do this, you should get that way, because if everyone's working really hard, getting better, then the entire practice should get better, which is just one of our examples. So we're really proud of this curve here. And lastly, I think it's important to know that we've been doing this for 18 years and we didn't get there in a minute. To adopt a growth mindset and becoming a learning organization, you're going to make mistakes. You're going to gather lots of data. It's not always going to go well. And the 10 lessons I just showed you are because we screwed up every one of those. So if you can, at the end of the day, meet as a group and decide, what did I learn today? I think that you will do better. So these are my 10 points. I think if you take a constructivist worldview, then you can still find value even if you don't hold the truth. But if it's true or false, people are going to argue that it's false. If you don't co-produce the goals, the second point there, people will argue with you that these are dumb and I don't like to be measured by this. If you don't build trust in the system and because the data is wrong, then they will disregard you. If you don't develop a shared mental model about attribution and contribution, people will conflate the two and get upset. I think you should work towards better, not best. Everybody wants to be the best, but there can only be one best in any group. Does that mean no one else has value? You can always measure better. You can't always measure best. So I work towards that. You should give credit for maintaining and improving care rather than just one or the other. Co-produce the visualizations that make sense for your learners, your people. If you're going to provide data, give it with guidance or people will get lost. Connect education to care outcomes, because all of this is what the Radical Lab is about, which is we're going to do these educational interventions, what happens to the patients. And when you can do that, it's extremely powerful. And lastly, be a learning organization. And I think you'll do well. I hope that's helpful. That's all that I have. I'm going to turn it over to Dr. Garibaldi.
Well, thank you so much, Eric. That was just a wonderful presentation. And I remember very fondly my first time coming out to University of Cincinnati and seeing the program that you've built with your team. It's really just incredibly impressive. I'd like to build on what Eric was talking about and show you how here at Johns Hopkins, we've applied precision education approaches at the residency program level. There are some individual applications that we'll get a chance to talk about probably in the question and answer session, but really I wanted to focus on the residency program level data. Here are my disclosures for today. And my objectives for the next few minutes are, number one, to recognize the relationship of time at the bedside with professional fulfillment, to restate the enduring value of the physical exam and show you some data that we've collected over the last 7 years in that regard, And then finally, to identify the value of direct observation to improve clinical skills, both at the program level, but also at an individual level. But first, I wanted to kind of set the context for where we developed our program. So this is a quote by Sir William Osler, where he said that medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from words heard in the lecture room or read from a book. See and then reason and compare and control, but see first. And this is William Osler at the Johns Hopkins Hospital, engaging in some of the cardinal maneuvers that we associate with bedside medicine. He's observing, he's palpating, he's auscultating, and finally he's contemplating. But if we were to head over to the hospital right now, at most of our institutions, this is what we would find. This is how our residents and trainees are spending time in the hospital. And this was ironically a picture we took on our clinical skills service, which was a service designed to actually focus on bedside clinical skills. And it's not surprising that as we spend less time in direct contact with patients and their families, skills that can only be practiced in the presence of patients are in decline. So this is just one example of a cardiovascular exam skill test that was developed by John Michael Criley, who was a fellow at Hopkins in the 1960s. And here on the x-axis is the year that you graduated from medical school, or the number of years in practice. And on the y-axis is the score on this cardiovascular exam test. So there's lots of data showing that clinical skills have declined. And this matters, right? You know, this is an estimate of the number of diagnostic errors that are made every year in US healthcare. And when people have looked at where these errors are being made, about half of errors are made in the physical exam. And when you further kind of parse out where those errors are being made in the exam, the most common error in the physical exam is simply that the physical exam was never performed. And this is such a widespread problem, but it's more than just the diagnostic component of things. There's value to both patients and to providers in the time that we spend together, particularly in the time that we spend examining patients. And I firmly believe, and there's emerging evidence, that some of the stress and burnout that we see, particularly amongst junior trainees and medical students, is related to the lack of fulfillment that people get from spending time in front of a computer and not spending time with patients. And so this led us to create the Graduate Medical Education Laboratory, which is a collaboration between Johns Hopkins, Stanford, the University of Alabama, at Birmingham School of Medicine, and our Society of Bedside Medicine. And this collaboration was funded in large part by the American Medical Association Reimagining Residency Initiative. And so I want to share with you some of what we've collected during GEL, with the idea that we want to collect data about the training environment to then use that data to inform interventions that can improve clinical skill, but also professional fulfillment. And so the first thing that we wanted to do is we wanted to really come up with a way of understanding how trainees spend their time in the hospital. And this has been done before in time and motion studies. Dr. Desai's I-Compare study, in which he led a large component of, followed interns around throughout the hospital for a whole year and figured out how they spend their time, but it was really labor intensive. And so we took advantage of an existing system in the hospital that really was initially created to track expensive equipment. It's called a real-time location system, or RTLS system. And right before the pandemic, we had most of our intern class wear one of these tracking badges throughout the year. We collected over 2 million unique observations. We had almost 100,000 hours of observation time. Just to put that in comparison, I-Compare had about 2,500 hours of observation time, and is still to this day the largest medical education study that's been done. And we detected interns for about 700 minutes for a 24-hour period. And this is what the data shows. So not surprisingly, it mimicked what was seen in I-Compare and other time and motion studies. Our trainees spend only about 13% of their time in patient rooms. They spend about a third of their time in the physician workroom. They spend a lot of their time also in the ward hall or in the hallways. And so we wanted to further break out how this time shakes out during the course of a workday. And so what I'm showing you here in red is data for the entire day. And then in blue is what happens during traditional morning rounds, which we defined as between 8:30 and 11 a.m. In our hospital. And so the chief resident service, which is our main internal medicine service, you can see that time in the patient room slightly increases during rounds, but time in the hallway goes up a lot. So we're getting out of the office. We're not spending time in the workroom, but we're spending a lot of time in the hallway. If you go to the intensive care unit where I work, there's unfortunately a drop in time that we spend at the bedside and a huge increase in the amount of time that we spend in the hallway. And finally, if you go to our subspecialty services, you can see that almost all of rounding is actually taking place in the physician workroom, and very little time is actually spent in direct contact with patients during rounds. And we've used this data to actually inform interventions to try to improve the amount of time that we spend with patients, particularly on our subspecialty services, where we've created workflows that encourage attendings to be able to go to the bedside with at least some of the patients, particularly new patients or patients who become sick overnight. And we've also begun to think about ways we can incentivize attendings to go into the room during ICU rounds and spend time with patients and their families. We've also looked at the individual data. So this is the 43 residents who had enough data for us to analyze as part of this project. And what's really interesting here is there's a huge difference between intern number 1 and how much time they spent at the bedside compared to intern 43. And if you average this out over the course of an entire year, intern 43 spent about 5 additional weeks of working time in a patient room. And that's really the goal of our project, is to figure out what is it that drives that difference in time at the bedside, and what is the difference in the experience that intern 43 had compared to intern 1? Are there differences in their clinical skills? Are there differences in the way that they think about their job and how they feel in terms of fulfillment and burnout? So we started to ask our residents those questions. And the first thing we asked them was, how much time do you think over the last month you spent in direct contact with patients? And so here in blue is the RTLS badge collected data. So again, we see that it sort of fluctuates a little bit, but it's pretty consistently around 13% or so. And what's surprising, or maybe it's not surprising, interns dramatically overestimate the amount of time that they're spending with patients. So here in March, people thought they were spending almost half of their time in patient rooms, which we know is clearly not happening in the hospital. But we wanted to ask the question, well, how does this time at the bedside, or perceived time at the bedside, relate to resident wellness and fulfillment? And so we had 3 surveys that we deployed at the end of every month, timed with the end of a rotation. One was the Connor Davidson resiliency score. One was the 2-question Maslach burnout inventory. And finally, we had the Arizona integrative wellness scale. And just to kind of put this into context here, anything above a 3 on the Maslach is considered to be burned out. And so our mean scores across this time period was 6.5. So clearly, this should not be a surprise that burnout is a problem in graduate medical education. But what was surprising is that when we asked residents how much time they thought they spent at the bedside and how they felt about their jobs, there is a negative or an inverse relationship between how much time they spent at the bedside and their Maslach burnout score. So the more time they felt they spent at the bedside, the less burnt out they were, the more resilient they felt, and the higher they scored on their integrative wellness. So certainly the time that residents think they're spending at the bedside is directly related to the way that they're thinking about their job over the previous 2 weeks to 4 weeks. And this is something we have to further investigate and really tie this to the badge data to see if this actually tracks with the direct amount of time that residents are spending. But time at the bedside clearly matters, and it impacts the way that you feel about your work. If we want to try to relate how we feel about our work and how much time we spend with patients to actual clinical skills, we need to directly measure those clinical skills. And I think it should come as no shock to this audience that we don't do such a great job of that in graduate medical education. We don't have very many opportunities to directly observe clinical skills. And so inspired by what they do in the UK, where there's a summative assessment that all residents must pass, in which they examine real patients at the bedside in front of attending physicians, we've created something we call APEX, or the Assessment of Physical Exam and Communication Skills, where we have a resident examine a patient with a specific issue, and they do that in front of 2 attending physicians who themselves have examined the patient or taken a history from the patient without any additional information. And they have to agree, this is what we think is happening with the patient. This is what we would expect a resident to be able to accomplish during a brief clinical encounter. And then following that encounter, we give directly observed feedback. So we've watched the resident conduct a history and physical, and then we can give them real-time feedback to improve their skills. And what's really wonderful about this model that we set up is that not only do the residents get feedback here, for example, a large physical exam finding was missed because many residents didn't take the gown down during a chest exam, but faculty actually learned from each other. So this was one of our chief residents who was paired with one of our senior pulmonary attendings. So they both learned from each other during this experience. This is an example of the current format where we have 5 different stations where residents will encounter 7 patients, 6 of whom have real findings on physical exam and real stories to share. And post-COVID, we added a telemedicine station, and we also have an integrated ultrasound station. And this is what we've learned. So if you actually plot out, this is data from the first 100 or so residents who went through this experience. If you plot physical exam technique compared to identifying signs, there's a positive and significant correlation. So technique matters. If you identify the right physical exam findings, you're much more likely to find or include the correct differential diagnosis on your list of differential diagnosis. So these exam technique matters and physical exam finding matters. But if you line up everyone who's taken this assessment by calendar month, what's a little bit concerning is that there's actually a significant decrease over time in how people perform on this physical exam assessment. And so I think this reflects the current training environment where we don't spend a lot of time doing direct observation and feedback of clinical skills at the bedside. And therefore, if you ask someone to do a reflex exam in June of their intern year, and they haven't done it since medical school, they're not going to be as good as someone who's asked to do that same assessment in September or October. Just wanted to share very briefly some of what we learned in terms of actual clinical skills. So this is an example where we had 109 interns examine the same patient with severe aortic regurgitation. And you can see here, these are scores that are normalized to 100%. Performance on identifying physical signs was pretty low in terms of actually getting the right diagnosis. And in fact, only 50% of the interns heard the diastolic murmur, and only about a quarter found a laterally displaced PMI that went along with his reduced ejection fraction. But as we watch people do this, you can really understand what are some of the techniques we need to teach folks. So first of all, less than half of the interns actually even felt for the PMI. So when we do our intro to the cardiac exam session with our interns, we make sure that everyone knows where a PMI should be, how to look for it, and what the significance of a displaced PMI will be. And then about 10% of our residents actually listened to the heart while they were palpating the radial pulse. And if you'll take a moment and put your thumb on your radial pulse and your index finger on your carotid, you'll recognize that there has to be a delay between your carotid pulse and your radial pulse, right? And so once we move people's hands from their radial pulse while they're auscultating to the carotid or to the PMI, almost everyone recognized that this person had a diastolic murmur. So that's something that we really emphasized from day one. Similarly, we had 160 interns examine the same patient with interstitial lung disease, and we saw a similar relatively low performance in identifying physical signs. And again, we learned what wasn't happening at the bedside. So when asked to do their best pulmonary exam in front of pulmonary faculty, 30% of our interns didn't palpate or percuss the chest, right? And so we teach that intentionally as part of our intro to the physical exam for our interns to make sure they understand why it is that it's important to palpate the chest. How do you do it? And when would be the right opportunity to try that on your patients. Similarly, for the GI exam station, we had a patient who had end-stage liver disease, and less than half of our interns palpated the spleen. So we've included this into our intern education day, making sure that everyone knows actually how to palpate for both hepatomegaly and splenomegaly. And I won't go through all the data for a neuro exam station. There is a real term in internal medicine called neurophobia. It's the internal medicine physician's fear of the neuro exam, and I think that's probably emphasized right here. We did pretty poorly in identifying physical signs, and what we really realized is that most of our residents, if they own a reflex hammer, most of them don't, but if they do, they don't have it with them when they actually examine patients. And so if you don't have it with you, you're not going to learn it. And so a few years ago, we looked into actually buying reflex hammers for all of our interns so that they have the tools they need to conduct their physical exam. So in conclusion, hopefully, very briefly, I've provided data to show you the physical exam is still relevant to patient care. Doing direct observation of clinical skills provides opportunities for individual feedback, but it also gives you the opportunity to see how you can improve the program and the way that we approach teaching these skills. I firmly believe, and I hope I've convinced you, that our trainees don't spend enough time at the bedside, and we need to figure out ways to gain back that time at the bedside, and that the time we spend with patients matters and is likely associated with professional fulfillment. So these are the folks that I'd like to thank and the grant sources that we've had, including from the American Medical Association. I will turn it back over to Sanjay so we can have some discussion with everyone.
Thank you guys so much. Just one observation before I have a whole list of questions to try to draw more out of both of you, but I just wanted to share how impressive your work is. I've had the privilege of seeing and experiencing the work that you do in person as well. And I think you guys are remarkable at synthesizing it to this level. But I think, and Eric, you made this point that these are data that are years and work that is years in the making, just to, I think, really emphasize that much of what's being presented and much of what we're doing in medical education has a long arc to it. And even more important, therefore, for us to have these conversations and to scale and to get started. But a couple questions that I'll try to point out to who they are most directly addressing, but I think probably all of these, both of you could comment on. The first is around trust in data. And Eric, I think you brought this up explicitly, and Brian, you alluded to it for sure. Everybody understands the issues around privacy and concern, a whole host of concerns around their data that may be sensitive. And Eric, you talked about building trust, and I think the comment that you made is around errors in data and fixing that to generate trust, which I fully appreciate. What if there's no error, but that people will sometimes react by saying, okay, those data are correct, but they're not representative, or they're not meaningful, or they're not sufficient to really give a description of my performance to date. So how do you continue to build trust beyond accuracy of data?
That's a great question. You said a lot of words there, sufficient, representative, those are all good words. Let's start with sufficient. I often talk about baseball. If you see a great pitcher who pitched one bad game, but you didn't see the other 29 games, then the one bad game is still true in what you observed. But the important thing is that you collected the whole. And so on any single event, you might have a negative or a poor performance. And we aren't going to put too much stock in that. That's the concept of programmatic assessment. The stakes of the decision should be proportional to the number of data points that you've collected. So a single data point should be a tiny piece of feedback, and it shouldn't hurt you so bad. Let's look at the whole thing, and we'll collect a lot more versions of the thing you've done. Even, for example, the thing we just heard from Dr. Garibaldi, like palpating the spleen. If they miss it, if they get it one time and miss it 27, it doesn't matter you saw it the one time. You can't conclude anything from one observation usually. And now, as far as that was sufficient and representative, I think those things are connected, and as long as you have a shared mental model about what you're doing with the data, you can get past some of the negative energy that might come back at you.
And Brian, maybe I'll add to this. You can react to that question as well, but just a corollary to it is there has to be a cultural shift, it seems, in the learning environment for people to have trust in data, and even to have trust in the assessments that you're doing continuously in your situation, literally continuously, but at certainly high frequency in both of your environments. How do you prepare incoming interns or new faculty to propel and promote this cultural shift that both of you are trying to nurture?
Well, I think the first piece for us, particularly around the clinical skills assessment, was making sure that we created a formative experience. So we're not interested in having, at least at this point, a summative high stakes evaluation where you have to pass this assessment where you see real patients in order to graduate from residency. That's not the point. The point is to demonstrate to them the value of these skills in real time, and to create opportunities where we can actually see them performing a history and a physical examination on a real patient, and we can give them real-time feedback to get better. And I think we've modified the assessment in ways that the feedback happens in real time right after you see patient one, and we're less concerned about how you did in station 1 versus station 3. We give you feedback in station 1 that we want you to apply in station 3 so that you can then get the next level of feedback. And so I think we've approached it as this is a formative assessment. This is a development for faculty as well as for trainees. And I think when they see junior faculty paired with senior faculty, they begin to understand that this is about all of us getting better. This isn't just about collecting data about physical skills, physical exam skills. It's about everyone getting better. The other thing that we've done is we've been very careful to go through the formal IRB. Rather than calling this a quality improvement initiative and just doing it, we've actually sought guidance from the Institutional Review Board to make sure that we're protecting our learners. In this case, the residents. We are using real patients, but they're volunteers and they're paid for their time. So we've really tried to make sure that from the get-go we've had protections for data security, but also making sure that this was not just us coming up with this idea. We've gone through normal channels to make sure that our learners are protected.
Thanks, Brian. Eric, let me ask you about the cultural shift. Then I want to shift a little bit to the theme of feedback, how you give that feedback, and how that process is going. But maybe around cultural shift, you've been at this, you said, for 18 years. And so what have you seen as the most important things to really, again, nurture the culture that you're establishing there at Cincinnati?
Tomorrow is the first day of orientation for our interns, and I'm going to spend the entire day talking about this moment, which is about growth mindset, which is about accepting feedback in ways that are positive. And I think we have normalized feedback, so everybody is going to get feedback. Everybody gets coaching, not just the people who, quote, need it. Everyone can be better. We've role modeled ourselves. All of us get the same data, so people can see that we're in on it together. And we talk a lot about sort of the shame reflex that many people have when they're receiving data that isn't optimal. Many folks that become physicians kind of grow up with a fixed mindset where an A is an A and a B is an F. Did you grow up in that household? Many people did. And so we try to get people around that, which is if you feel the shame reflex that somehow you weren't, quote, perfect, you can detect that, you can reflect on it, and you can reject it and move into the growth position, which is, okay, I'm not perfect, but I can learn something, and that's okay. It takes a lot of nuance, a lot of hard work. And even if you set it up perfect, people still have to do that work. And if they don't, it still can be a difficult conversation.
So building on that, Eric, can you describe maybe some negative behavior changes that you've seen when you're giving the data? And Brian, just to follow up for you after Eric responds, Dr. Pangaro actually asked in the chat if you give back clinical skills feedback, which I know you do, having been part of that program, and how you do that and how people react, and any experience that you want to share there. But Eric, first to negative behavior changes that you've seen when people have received these data.
So I think that two of the major pieces of negative behavior change that you may see, and think about your own life and your own leaders and the things you can measure on, are cynicism, which is this initial idea that the idea must be brought down, whatever it is, and contempt, which is actually worse than cynicism, in my opinion, which is this idea that you don't even want to try to fix it. You just want it. The person is bad who's delivering it, and everything is bad. So if you get cynicism and or contempt in the people that you are trying to lead or trying to move it, that's not where you want to be. We call it getting lounged, where the residents go off into the lounge and talk about how bad things are. So if you've created that or been part of that, you know what that's all about. And you're not going to move forward. All that energy that's going into that is not going in towards improvement. So I try to listen hard for that, understand why it happens, try to mitigate it.
Thanks, Eric. Brian, the feedback related to clinical skills.
Sure. So it happens in a number of different places. So first and foremost, during the actual assessment, we provide real-time feedback. So if you spend, for example, you got 10 minutes to do a physical exam, or 6 minutes to do a physical exam on a patient, we say this person has chest pain, do a cardiovascular exam. 6 minutes to do the exam, 4 minutes to present your findings and answer questions from faculty. You then get another 6 minutes of direct feedback, which, in the room, in the moment with the patient. If you miss the PMI, we move your hand to the right spot. If you miss the murmur, we listen to the murmur, sometimes with a digital stethoscope, to make sure that you understand what the findings were that were missed. But then we also give a score sheet at the end, showing you exactly where you were doing in different clinical domains. There are 7 clinical domains that we provide feedback on. So you get the faculty score sheets with handwritten comments, you get your scores. And then I offer to meet with every single resident who goes through the assessment, and we go through, hey, this is what your goals are for this coming year, and how can we help you achieve those goals. I'll be honest, not every resident comes and meets with me. It's probably 5 to 10 residents per year that will sit down and actually go through these score sheets with me. But the ones who do, we really follow up on these action plans. I will go examine patients with them in the hospital. If they want to get better at a neuro exam, we'll go over to the neuro ward and we'll examine patients. If they want to get better at ultrasound, first we'll examine the patient with traditional cardiovascular exam skills, but then we'll ultrasound the patient. We'll do real-time bedside sessions to help people achieve the goals that they want. And what's been really amazing is some residents have really taken this to heart. And there's a group of second-year residents right now who really want to get good at the cardiology physical exam and ultrasound. They've generated their own curriculum that they're going to deploy to our interns next year. And we've done probably 15 bedside sessions with the 5 of them, where they are at the point where they're just teaching each other exam skills, and I'm just there to learn from them. And so I think when it works, it really has created a whole new generation of physicians who are invested in these skills, recognize their value, and want to actually integrate traditional physical exam skills with technology, which I think is really the next step, is how do we intelligently incorporate technology into our bedside practice.
Brian, there's a bunch of questions here related to the GEL study, and I'll try to combine a few of them into one. But essentially, they're asking, and Dr. Diachin is one of the people that's asking this question, what are some other conclusions you can draw from this research? So, for example, those that spend more time at the bedside, are they also working more hours? How does it relate to EMR activity? Are there patient-related outcomes that you're able to assess from this? And then personally, I have a question. How do they feel about being tracked?
Yeah. So I'll start with the tracked one. When we started using the RTLS badges, we were very careful to put together a focus group of residents just to say, hey, what would you guys feel about this? When we do track them, we're not tracking them in real time, so I can't pull up something on my computer right now and tell you where resident X is on service Y. We get a de-identified download once a week about where they spent their previous times. We don't have sensors in bathrooms and call rooms, right? So we're not tracking them during break times and things like that. And by and large, the residents have been on board with it. The IRB actually said, you should require this of all residents. You shouldn't even ask them, but we have an informed consent process. We give them a badge at orientation. And we say, hey, if you want to take the badge, it's on your lanyard. If not, please give it back to us right now, and you don't have to participate, and they can give it back anytime that they want. I'd say we have ups and downs in terms of how many residents wear the badges at any given time. It's usually about a quarter of the program that's wearing badges. So it's not everybody. And certainly, I think after COVID, people don't wear lanyards as much. They don't wear white coats as much. So there's less things to attach these badges to. So we've probably lost some uptake there. But by and large, people actually want to know how they're spending their time. And we also give them quarterly feedback where we say, hey, this is how you spent your time in different locations compared to everyone else who's been wearing the badges. We don't give them guidance for how to change that particular behavior because, I don't know what the right amount of time to spend in a workroom versus the hallway is, for example, but we allow them to have that data. And those who have worn the badges have told us they really appreciate being able to know how they compare to everyone else who's wearing badges. The places where we need to move in the future, and I think Eric sort of talked about this, it's hard to attribute individual clinical decision making in the hospital to any one individual, right? So if one individual spends more time at the bedside, how does that actually equate to patient care outcomes if they're working in the ICU on a team of advanced practice providers, residents, fellows, attendings, right? So I think that's the nut we have not yet cracked, is how do we actually attribute differences in clinical outcomes to individual time at the bedside, for example. The other piece that I hadn't talked about, which is something that's still in progress, is layering on all the incredible data you get about behavior in the EHR. So not even looking at clinical outcomes data in the EHR, but simply how much time do you spend on the chart and where are you when you're spending that time? Are you somewhere on site? Are you off site? What are you doing in the chart? Is it lab review? Is it note taking? Is it responding to, in our case, secure chat messages in Epic? Some of our trainees, they're averaging about 300 secure chat messages a day, right? And that obviously impacts workflow and prevents you from paying attention to certain things or having dedicated time to think, right? So all of those other data streams need to be incorporated into the data I showed you. And that's sort of we have 1 year left in our Reimagining Residency project, and that's the big goal for this coming year, is to layer on the EHR metadata on top of time at the bedside, clinical skills data, and professional fulfillment data to see where we can maybe move the needle.
Yeah. Both of you described the need for faculty. It takes a village, and I know this well from my own experience, to really move these systems forward and to create the cultural change and to implement these systems of precision education and feedback. So maybe starting, Eric, with you, but what have you found important or successful in engaging faculty in the work that you're doing, which is, again, so many in the context of so many more operational and administrative pressures that our faculty are feeling?
This is a very nuanced conversation, because when you think about receiving data and your own sense of vulnerability, you would think that the faculty would be okay with it, but they are often the most vulnerable people because they're supposed to be kind of done, right? There's no growth mindset when you graduate. And so much of the cynicism and contempt that you see, actually, I can only speak to the environments that I know of, about data come from the faculty, about their own data. And so I think this, in a weird way, we're way ahead with trainees than we are with faculty. You're talking about receiving data and role modeling. You also might be talking about just people to kind of do all the coaching and all the analytics. My team is huge now because I can't do all this work, and I need coaches, I need analysts, I need dashboard designers. I think you have to build a team around you as you gather information. So that's two sides to a three-sided coin, which is how do faculty receive data? How are you managing their kind of coaching themselves? How are they remodeling the behaviors you wish to see in learners? And then what team do you build around you? I just want to follow up on what Brian said. We did a lot of metadata analysis for the last 2 years, and just following up with that idea that we found this kind of weird, this is not published yet, it'll be published soon, we hope, a Starling curve of people who type at night. A little bit of typing at night is good for your patients, better outcomes, and then there's a drop off, and it's really interesting. So what do you tell people? Should you type a little at night? It's actually a dangerous thought.
It's the first time I've seen the Starling curve applied to that particular context, and appreciate it, Eric. Brian, faculty development, how do you, faculty engagement in the work that you're doing? You obviously need this critically just to implement and operate Apex as you described.
So I would say it's probably the biggest challenge coming out of COVID has been getting faculty preceptors to be able to spend more time with us, particularly around Apex. And obviously people are being held to account for their time a little bit more, and it's really hard, particularly for outpatient clinicians, to give up a half day of clinic to come spend a half day with us teaching residents. So I would say we have a core group of folks who are in positions where they have protected time to do medical education, and so we rely on them very heavily to come. But we've also actually tapped into two incredible resources that I think have really enriched the program. The first is that we have an academy of retired professors here at Hopkins who have agreed to stay on, and they spend a lot of time teaching medical students and residents. And so we have 3 in particular who come to almost every one of our Apex assessments. And they've just been an incredible resource for me. I've learned so much from them in terms of the way that I approach patient care. But they also have just been an incredible resource for our students. At the same time, we've actually really tapped into the Society of Bedside Medicine and created an experience where people who are interested in developing their own bedside teaching skills, or maybe want to start their own bedside teaching programs at their home institution, we invite them to come precept Apex, and they come in the day before. We have them round with us on the Ulster Medical Service. We have them meet our residents. Usually they do a noon conference talk, and then the next day they spend in Apex both teaching our residents, so it gives our residents an outstanding opportunity to see how medicine is practiced at other institutions, but then we also pair them with someone who's done the assessment before, so they can learn a little bit more about how we actually set, how we calibrate the assessment at the beginning of the day and agree on findings, how we decide what, if someone has 15 different physical exam findings, how do you pick the ones that are probably the highest yield to teach on? And I would say that, so the challenge of finding faculty has led us to tap into 2 incredible resources that have really enriched the program and certainly made it a better experience for the residents and our current faculty.
That's terrific. A question that came in from Dr. Gottman, and pardon me if I'm mispronouncing the last name. Really important, I think, competency that we all are aware of is communication, but it's often harder to assess, particularly with the volume of assessments and the longitudinality that we require. So curious from, again, Dr. Gottman, is there assessments that you have that relate to a trainee's ability to educate patients about diagnosis, prognosis, current treatment options, and outcomes data? And I'd expand that just to communication generally.
Sure. So one of the 7 domains that I talked about earlier in Apex is communication. And so some of the stations are straight up physical exam stations. You get a chief concern and you go in with a targeted, do a lower extreme, do an exam for someone who's having difficulty walking, right? But some of them are actually a focused history and physical, where you get a door note, sort of a letter, referral letter. And so you do have the opportunity to see how they approach taking history and communication. And actually one of the stations is just a shared decision-making standardized patient case. That's the only standardized patient case that we have, where we have an opportunity to see we have several scenarios we use, but we get to see patient, how our residents counsel patients on, taking medications or following up about certain chronic diseases. So we do have an opportunity to do that. I would say that's something that is a much smaller piece of the larger Apex experience and something that we need to expand on.
Eric, what about in your program? How do you, what types of assessments do you rely on for communication?
So in the ambulatory setting, we ask patients directly about each person, and they get 7 questions. So they call you with results, communicate well, spend enough time, those kind of questions. And so it's really easy in the ambulatory center because I have sort of an attribution thing, which is this is your primary care doctor. Whether or not they delivered all the care, we're not going to argue about that. I find it much more difficult in the hospital when they go in there because there's so many people on every team, and I've not been able to crack that nut just yet. Directly from patients to residents in the hospital. Clinic, we've got a hospital, we don't. We do collect all kinds of communication questions all around the residents from all different perspectives. So when you're on the wards, you're going to get assessed by your peers, your attendings, the health professionals, just not the patients on the inpatient side. So it's not perfect, but what's interesting is that what we found, and I can show you plenty of examples of this, where the faculty think one thing and the other people think another. And that's a real ripe conversation for feedback.
That's great. We're unfortunately closing in on time here. Maybe one more question, and both of you will have a moment to answer. Sort of imagining your aspirations for the future. You're working and leading innovation in residency programs. You both are practicing physicians, and you both went through medical school. So where do you see the upstream and downstream aspirational outcomes of this, extensions of this work? And maybe just a couple of points each, and we'll unfortunately getting to the point where we're closing. But Eric, we'll start with you and then go to Brian.
Yeah, Brian mentioned this. It's so labor intensive. What if we could collect data automatically and synthesize that data automatically through AI or some other version of that, and then have the tool actually be helpful to you? So either starting the coaching or doing the training itself. So for example, let's say that you're struggling with a particular aspect of the EMR, or approaching a diagnosis next week that you don't perform well on. Could we build tools that would help people get better in the moment? Not solely just giving them data, but actually helping them. That's an AI kind of chatbot sort of interactive platform. I don't know where the future is going, because that's fraught, but you can imagine that humans cannot do all the things that computers can do. How can we best harness that?
Terrific. Brian?
Yeah, I agree with Eric. I think for me, when I think about time at the bedside and what the road back to the bedside looks like, I think it's through technology, right? I think it's about integrating the best of traditional touch with, current opportunities in tech that can either offload work streams to provide us more time to spend with patients. So instead of spending, 75% of your time looking through the EHR, you have a tool that allows you to pull out the important information so you can divert that time to spending it talking to patients and examining them, but also at the same time leveraging emerging technologies to do things better or more efficiently. So for example, digital stethoscopes, both for teaching, but for making sure that we're making the right diagnoses, using point of care ultrasound at the bedside. I use it on almost every patient in the intensive care unit, and I think of it as an extension of the physical exam or part of the physical exam, but it's never going to replace basic observational skills. So how do we teach both, and how do we leverage the promise of both, and think about ways that we can spend more time with patients, both for their benefit, but also for our benefit, right? I mean, no one went into internal medicine, at least, to sit in front of a computer all day. And I think there's value in the time that we spend with patients, not just for the patients, but also for us.
Well, unfortunately, we're out of time. I want to start just by thanking Brian and Eric for your time today, for speaking with us, but even more importantly, for leading the work that you're leading, because it really is an example and a role modeling for all of us to learn from. So thank you very, very much. I also want to thank everybody for joining us this afternoon. And I regret that we were not able to get to all the questions related to coaching and other technologies and other ways of integrating data in the future. Hopefully we'll have more sessions to get to all of those things. We do encourage you to read more about precision education and learner assessment. You can do that by downloading the Academic Medicine Supplement, by scanning the QR code that's on the screen right now. And again, a reminder to please complete the post-webinar survey with this QR code, and it helps us inform ourselves about how we might design programming that's going to be most effective and most valuable for all of you for the future. For more information on ChangeMedEd, please visit changemeded.org. And again, thank you all for spending a little time with us this afternoon. We wish you the best.